Okay, we have a little music until they are coming.
הלוואי ומענן תרד עלינו קשת, הלוואי שלעולם הזה יש
Yes, we are with music already.
אתה לא שומע?
הלוואי ויום יצמח מתוך סופה גועשת, הלוואי ולא תאבד לעד המתנה, הלוואי שהמדבר יצמיח עשב דשא, הלוואי ועוד נשב בצל התאנה, הלוואי שלא נכאב ואיש אחיו יאהב, הלוואי ויפתחו שוב שערי גן עדן, הלוואי ויתמזגו מזרח ומערב, הלוואי, הלוואי ונחדש ימינו כאן כקדם, הלוואי ולא יישא עוד גוי אל גוי חרב, הלוואי ולא ננטוש את דרך התקווה, הלוואי והאדם יהיה רחום עד הערב, הלוואי שיש סיכוי אחד לאהבה, הלוואי שלא נכאב ואיש אחיו יאהב, הלוואי ויפתחו שוב שערי גן עדן, הלוואי ויתמזגו מזרח ומערב, הלוואי, הלוואי ונחדש ימינו כאן כקדם.
הלאה בועז. זה מאוד יפה.
שלא נכאב ואיש אחיו יאהב, הלוואי ויפתחו שוב שערי גן עדן, הלוואי ויתמזגו מזרח ומערב, הלוואי, הלוואי נחדש ימינו כאן כקדם, הלוואי שלא נכאב ואיש אחיו יאהב,
סיימנו. זהו, נהנינו ממוזיקה.
I gotta start dancing now.
No, good evening. I will start in Hebrew and then we're gonna we won't translate, so we'll start with Hebrew and then we speak English, okay? אז קודם כל, ערב טוב לכולם, ערב טוב חברים יקרים. יש לנו היום וובינר מאוד מיוחד, כי היום נמצא איתנו אורח כבוד, שכנעתי אותו, הוא יהודי, הוא מאוד התרגש לתת היום הרצאה, עברית הוא לא יודע, ודוקטור ריצ'רד טרושקובסקי, אז אנחנו תכף נעבור לאנגלית ואנחנו נציג אותו, ואני מקווה שאתם תהנו, ההרצאה היא באנגלית, אני מאוד רציתי גם לחשוף אתכם אליו וגם לחשוף אותו קצת לזה שגם אנחנו יש לנו את הפעילות שלנו, אני לא ארחיב היום בשיחות נפש, אז היום אנחנו נהנה ממנו. Yes, good evening, Dr. Richard Trushkovsky from New York. Thank you for being with us. Good evening, Michal from Colgate. Michal, you will excuse me, I want to introduce Dr. Richard because everybody knows you, and not everybody, and most of the people we don't expose to American association and American scientists in our field. So thank you, Dr. Richard Trushkovsky, that you are here.
Thank you.
Dr. ריצ'רד טרושקובסקי will give us a lecture in the subject of discolored dentition, from diagnosis to treatment, simple solution to complex care. Dr. Ríčרד is adjunct clinical professor in NYU College of Dentistry, in the faculty APA Advanced Clinical Fellowship in Aesthetic Dentistry for International Dentists in NYU. He will be published also in our newspaper, IDA newspaper, רפואת הפה והשיניים. I hope you will be able to read his articles also in our papers. So thank you that you are here. Thank you for your time. I'm glad that you are here, and if you will be able in the future to expose us, to give us more subjects, more interesting subjects in other dental issues, so we will be glad to also to be here if you will be able to share it with us. So the microphone is, I give the microphone to Michal. Michal, good evening. How are you? It's good to see you with us. Today we are talking about Colgate, and then with Dr. Ríčרד Troskovsky, we are here. If there will be questions or something, I will help you. Dr. Richie, we give a few minutes to Michal, and then the stage will be yours, if it is okay, if you are agree.
Definitely. Thank you.
Thank you very much. תודה רבה. מיכל, בבקשה.
אז ערב טוב לכולם, אז אני מיכל, thank you very much Richard that you are coming to our webinar and our program.
Dear Rich, the microphone is yours.
Okay. I was just looking at my bookcase. I do have Zucchelli's book. I used to carry some of these books about carrying them around. I get big muscles carrying around, but it goes into my brain. Okay, thank you. So I'm going to share the screen. Can you see me? You see it now?
You can share.
Oh, let's see. Okay. I will. Hold on a second. Okay. Okay. The dentistry, I know it's working with my Mac computers. That's a whole other story. Okay, we should be. Oh. You should see it now. I'm going to go to the full screen. Yeah. Okay, 1 second. Okay. Okay, we're good?
Good, yeah.
Okay, that's the hard part. Once I get that, then I can relax now. Again, I want to thank Shalom to everybody. I know it's 9 o'clock in Israel. It's somewhere after, 2:15 here in New York. I want to thank both of my hosts and the Israeli Dental Association for having me here. And I'd love to do more that I could give Lior more topics that I could speak about. Being at NYU at the international program allows me to treat a lot of interesting cases, much more so than my private practice. People come basically for aesthetic treatment there, and really the key to everything is diagnosis, because sometimes you could do something very simple and make the patient happy. You have to think is what's best for that particular patient at that particular point in their life and how to do it in the best way possible. And I'm trying to give you part of the webinar will be to introduce you to several different options you can use for the discolored dentition. Teeth change shades over a period of time as we get older. Like I could speak for myself, as I get older, my teeth have changed in shade somewhat. Some it's more drastic, and determining what's best to do for that patient is part of what I'm going to be discussing. I'm going to give you an outline. This is the discolored dentition diagnosis and treatment, simple solutions to complex care. And I gave you at the beginning, I could give you again my email address. I have a couple that I use, mainly the NYU one. If you have further questions in the future or want more articles on the subject, the only problem with that is once you ask me for articles, you're going to have to get a couple of computers, as my students know, because I have a lot of stuff that I could share with everybody. And you're going to have to get a lot of accessory drives to accommodate everything. Basically, the participants will learn how to differentiate fluorosis from other enamel and white spot lesions. You can assess depth using transillumination. That's a key to guiding the treatment planning. Sequential minimally invasive therapies include bleaching, microabrasion, and resin infiltration. You can determine when to use conservative treatment as appropriate versus more restorative intervention. You can enhance aesthetic outcomes while preserving natural tooth structure. Step-by-step sequence treatment. Initially, you're going to do a complete oral examination before any work is done. Full oral exam, x-rays if needed. In school, we're doing scanning rather than impressions, but that's when we're getting into more complex treatment if it's needed. You have to identify the cause of brown spots. Could be decay, could be fluorosis, staining, white spots, demineralization, early cavities, or fluorosis. Overall, dark tooth color could be intrinsic or extrinsic, could be non-vinyl, or it could be tetracycline staining. This determines which treatment will work and which won't. That's before you start treatment, is to assess different options. Again, what's best for that particular patient. First, you're going to do a cleaning, remove surface stains, plaque, tartar, and make the true color really visible. And you might want to do some whitening, and that'll prevent some unevenness. So ideally, a lot of times we lighten the teeth. That's the first step. And that'll reduce the appearance of mild brown stains. You have to treat any active decay, structural issues if present. If brown spots or equal cavities, you should fill them and do minimally invasive treatment first. Resin infiltration is for very early lesions. Whitening should never be done on untreated decay. Professional cleaning and polishing, we mentioned that. I'm sorry, I'm going backwards. Okay, white spots usually become more visible after whitening. So you have to tell the patient initially those white spots are going to be more intense. And throughout treatment, we're going to gradually minimize or eliminate that discrepancy between the white spots and the natural tooth structure. Remineralization therapy should be started first, sometimes fluoride varnish. CPP or ACP products like MI paste used for early demineralization. Resin infiltration or icon is ideal for white spots from braces and early enamel lesions. So mask white spots by matching enamel refractive index. This is often the best first cosmetic solution. Microabrasion removes very superficial white, brown, and enamel defects and is often combined with resin infiltration. When I wrote the article, and I had seen something in QDT, I think it's not last year or the year before, with an article, and opened my eyes with some of the modifications that were used prior to the icon infiltration. And recently, DMG modified their protocol, and I'm going to discuss that in a little bit more detail, because updating the protocol makes it more efficacious. So sometimes if white spots persist, cosmetic bonding, small resin additions, blend color discrepancies is conservative, and sometimes it could be reversible. Veneers or crowns are the last resort, but sometimes it's required to be more predictable and get the best aesthetics. At the end of the presentation, I'll show you some cases that some of my students did, and I published on. There's a couple of things recently and one in the previous years. So it's most invasive, but most predictable. Dental fluorosis usually appears as diffuse, symmetrical white streaks or patches across multiple teeth. Remember, it's diffuse, often in the same areas as homologous teeth. In contrast, other white lesions, like those of early caries, are usually localized, asymmetrical, and have a chalky, opaque appearance near plaque retentive areas. Symmetry and diffuse distribution are key for clues of fluorosis. Early enamel hypomineralization related to developmental defects of enamel is an aberration in the quality of dental enamel caused by an insult to the ameloblast during amelogenesis. Clinically, these lesions are called enamel opacities and present a change in the translucency of the enamel with appearance ranging from white to brown and vary greatly in their size and shape. That's very important. I have, like I said, some sample articles, but like I have 40 or 50 articles on the subject that I could send to anybody that wants further interest in pursuing the subject. But it's combined talking about the aesthetic management of stained enamel opacities, external bleaching followed by resin infiltration. White spot lesions, what causes the defect? It's defect in the structure and mineralization. These optical changes occur mainly due to presence of empty spaces between the hydroxyapatite crystals, which are now occupied by organic fluids. The difference in the refractive index of the fluid, basically composed of water, which is 1.3, and enamel, which is 1.62, leads to the visual identification of the porous area of the enamel as a white spot. The increased porosity located in the enamel can have a pre-eruptive etiology. Could be prior to eruption, something happens while the tooth is forming due to alterations, such as dental fluorosis, traumatic hypomineralization, or molar and incisor hypomineralization, or post-eruptive as dental caries. Icon smooth surface flow. I'm going to be discussing basically the smooth surface rather than interproxal. I'll mention that briefly when I go over diagnosis. Now, how does Icon work? It's going to penetrate the pores, and you get better blending of the material. Let me go back. Okay. What is Icon resin infiltration? As I illustrated with that sponge, I saw a speaker doing it. It took me about 10 minutes to figure out how to do it, but keeps me busy and out of trouble when I do some of these things. I like learning how to do different things. I love learning. I like teaching. But in any case, back to what is Icon infiltration. It's a minimally invasive treatment that arrests early, non-cavitated lesions developed by demineralization and white spot lesions developed by fluorosis. How does it work? You can apply a low viscosity resin that enters the tubules of the enamel and using the refractive light index to match the shade of the surrounding tooth structure. First, you can apply the Icon etch, which is 15% hydrogen chloride. It opens the porosities of lesion by removing the pseudo-intact surface layer and allowing the infiltrant to enter the enamel. And I'm going to show you the modification of that in the newer protocol. Icon etch, Icon dry is ethanol alcohol, and it's used to dry the tooth and provides a quick preview of the lesion. That's very important because during icon dry, you want to preview the lesion and see whether it's ready to apply the icon infiltrant. If you do it too quickly, you're not going to get a good result. So the icon infiltrant is basically a low viscosity methyl methacrylate resin that enters the porosities of the enamel. So it's, as I mentioned, this is for smooth surface. I found that interproximal, I did in my office, very difficult to use. And one thing I'll mention, it doesn't show up on the x-ray. So if a patient goes to another dentist, they're still going to think that there's still a lesion present. But I'll allude to that a little bit more briefly in a few minutes. So icon infiltrate penetrates the lesion pores, blocking the demineralization acids that cause the lesion to grow deeper and larger. It stops the lesion progression by setting up a diffusion layer. See over here. Improves the aesthetics by replacing the demineralized enamel with the infiltrant, which makes the lesion disappear. Appetite is 1.62 while air is 1. So what happens is once you apply your infiltrant, which is 1.46, it'll pretty much mask the appetite, which is 1.62, so the white spot will virtually disappear and blend in with the surrounding tooth structure. So why use icon infiltrant? It reinforces, strengthens, and demineralizes areas. It fills and closes microcavities. It minimizes risk of secondary caries in the treated area, improves the aesthetics of the smooth surface. And there's a lot of clinical studies. It takes one visit, no anesthesia or drilling is required, and patients love it. So what's the protocol? Icon etch is applied for 2 minutes, rinse and dry. Now with modification of it, I'm going to show you a list, and I could send, I got from one of the representatives of DMG, the current protocol with that. It's a 2-page identification of how to localize. I have it on my other computer screen I'm looking at right past what I have here, but you can apply the icon etch for 2 minutes, but sometimes, depending on the lesion, I'm going to mention to you, you're going to use microabrasion or maybe a finishing burr or a diamond to remove the superficial layer of the lesion first, depending on the lesion, using transillumination to determine whether that's necessary or not. And the icon etch, you apply for 2 minutes, rinse and dry, and you might apply it up to 3 times. Then you can apply the icon dry, which is the ethanol lesion, for 30 seconds, and you evaluate it by transilluminating. I'm going to show you in next few slides the transillumination and when to determine whether you could go ahead or not. Icon infiltration is applied to lesion for 3 minutes. Actually, we did something recently up to 9 minutes with that. The longer you apply, once you determine the infiltrant is ready to be applied, the longer you apply, the better the infiltration. So that's a modification or change. It's more than a modification. It's a lot of changes to the previous protocol. Interproximal caries, if it's through the DEJ, I wouldn't use that technique. If it's near the DEJ, you can use it. I'll show you another material that I would recommend and possibly use that in Curodont material in conjunction with the icon material. White spot lesions, definitely great for. Brown spots, combination of microabrasion, bleaching, and maybe the icon material. So which technique to use? That's one of the most difficult parts. First is diagnosis, and then which technique to use. So this is the new treatment protocol. You want to prepare it, you want that photography, diagnose the lesion type. Transillumination is critical to determining the lesion type, and then you determine the treatment protocol. Pre-treatment, now, a lot of times, pretty much all the time, I recommend bleaching first. It could be in-office bleaching or at-home bleaching material. Then you have to assess the condition of the material, and you might want to use microabrasion and then use the icon etch and then the icon dry. And that infiltration time is going to change to get the optimal result. What are the depths of the enamel opacities? You have to look at it. You're going to look at it. It could be superficial, it could be mixed, or it could be deep. And that'll determine what you're going to do with the proper treatment. So transillumination, again, is critical to determine whether it's on the surface or how deep it is and so forth, because that's going to change your treatment protocol. Pre-treatment bleaching removes the local discoloration, increases overall whiteness. It'll neutralize color differences in both unaffected and affected teeth. Removes proteins in the lesion that hinder infiltration process. Use carbamide peroxide bleaching gel with 3D printed trays, or you can, just make it with an Omnivac, or you could do in-office bleaching. You do that first, but you got to tell the patient beforehand the white spots are going to be more intense. And there's another article, regarding masking efficiency and the resin infiltration, just to illustrate the point. All right, so resin infiltration alone will improve the appearance, but using the bleaching first a lot of times makes it more efficacious. So pre-treatment bleaching and whitening, use 5 to 10% peroxide, low slope approach. Could be an hour a day or up to 10 days. It's suitable for young patients during the treatment of enamel opacities, or adults require gentle bleaching due to sensitivity. If they're not sensitive, you could use a more aggressive bleaching protocol, and you could use a 3D printing tray if you have that, or you could use an Omnivac with a different tray material today available from different companies like Ultradent. Diagnosing the enamel opacities. Next few slides are critical for your proper diagnosis. What we see on the surface discoloration is the surface area affected, the texture. Lesion diagnosed in a natural light only show what's going on the surface of the enamel. So you have to determine what's going on underneath the surface. Transillumination, you shine a light through the lingual aspect of the anterior tooth, and you can see over here on the right, that it's not on the surface, the lesion. So it's well demarcated, and if it's diffuse or demarcated, depends on your treatment. So how superficial or deep a lesion is, are the margins demarcated or diffuse? Assists in depth determination. How much of the tooth is really impacted under the surface? So transillumination using a suitable light source positioned on the lingual surface of the tooth projects a shadow of the lesion. As you can see over here, a demarcated lesion and a diffuse lesion. So the diffuse lesion, a lot of times it's going to require more preparation prior to doing your etching with your icon material. Transillumination light pen, Adent makes a great transilluminator. It's the Microlux material. They have several different ones. There's a basic one. They have a more advanced one. And you can use it for also locating composite on the teeth with the more advanced one. If you have remnants after orthodontics, you want to remove that first. So icon smooth surface treatment. Superficial lesions, distinct margins indicate superficial opacities without a thick surface layer. Icon etch alone will be sufficient to gain access to the lesion. And as you can see over here, very distinct margins of the on that tooth. And then 2 rounds of etching were necessary to indicate to diminish the thin surface covering the lesion. And then you apply the icon etch for 2 minutes, rinse dry. Icon dry is applied for 30 seconds and drying the lesion. All right, and then after completion of infiltration, you see the lesion virtually disappears. But when you apply the icon dry after the icon etch, if you still see very distinct lesion, you're probably going to want to do it again because it should virtually disappear at that particular point in time. Otherwise, you're not going to get a good result. Again, this comes, unfortunately, with experience with the different lesions of how long and how many times to apply different materials. Transillumination used the principle of light scattering to increase the contrast between the sound and the hypermineralized enamel. For anterior teeth, the light source applied at the lingual surface, and light transmission is then observed from either the opposing side. Clinically, enamel hypomineralization appears dark because it's demineralized, porous, and light is scattered more than sound enamel. The diagnosis of enamel defect can be performed through visual examination. So you want to consider the shape, size, color, and location of these defects. The depth of the lesion is an important factor to be analyzed in order to define the treatment. So you want to transilluminate the darker area, transilluminated the spotted appear even darker, the deeper it will be. So the darker when transilluminated, the deeper the defect will be. Traditionally, the treatment options for pre-eruptive white spots were tooth whitening or microabrasion, and the restorative technique for deep spots. The use of infiltrant, a low viscosity fluid that penetrates the body of the white spot due to capillarity, has been proposed to mask the appearance of the enamel defect. As I mentioned before, it has a refractive index about 1.52, and that's closer to that of healthy enamel. So you want to look at a preview of the lesion. I'm sorry, go back. You look at a preview of the lesion after you etch it and you apply the icon dry. You want to see what the lesion looks like and ascertain whether further etching or treatment will be required. Clinical image and the schematic drawing show the preoperative appearance of the type 2 lesion affecting the central incisors with a non-homogeneous body and the appearance after removal of the surface layer and the appearance after the lesion has been transformed from a more diffuse to a more definitive. So you go from the left to the right. So deep lesions, vague margins indicate opacities that are deeper and the enamel have a thick surface layer. More extensive surface removal is required. Microabrasion, it could be, I'll show you briefly with the Ultradent material, or use a diamond or a finishing burr. And you want to show the vague margins over here in the lesion, and then using a diamond drill, they're reducing the surface layer and then using the etch and then use the icon dry, and then you should see the lesion virtually disappear, and then you can apply the infiltrant. If you don't see it disappear, you want to go through the process again up to about 3 times, and you got to reevaluate. Okay, so different options for removing the surface layer of deep opacities must be fully accessible for infiltration. Prepare the lesion for infiltration by microabrasion, blasting, with micro oxide and a micro etcher or partial use of a diamond drill. Transillumination to monitor success. Do not use a curing light, though, during the infiltration step. Because once you use the curing light, you're going to harden the material and you can't go any further at that point. So you want to optimize your patient communication by giving a patient a definitive proof of success. So you want to apply the icon infiltrant for more than 3 minutes. In the case we did recently, we did it for 9 minutes. The longer you allow the infiltrant to enter the lesion, the better the outcome and success of treatment. Bleaching before icon treatment is available, but you want to wait 2 weeks prior to treatment because the etchant, well, the infiltrant, the resin, as you know, most people know with bonding, you want to wait 2 weeks after bleaching because that's going to affect the bonding technique. It's not going to work well, so you have to wait 2 weeks. And also you want to wait till the color comes back and compared to the bleaching, what the final color will be. And this is the new protocol source for the infiltration. Like I said, I could send anybody interested the current protocol that's over on the right. And you could get further information from ION DMG, and they have videos. That is a summary, and I'll go step by step with doing that. The initial situation, white spots, it might be after removing braces. Results, treating with the icon etch, and then you can apply the icon dry and transilluminate it at that point. And if the lesion virtually disappears, you're good. If it's still a lot, you can apply the etching again. You might do that several times to do it. And if it's more diffuse, you're going to do the microabrasion with whatever technique you'd like to use. And then the application of the icon infiltrant. All right, and then you're going to polish it afterwards. This is a case we did many years ago in the Rosenthal Institute at NYU. That's when I first became familiar with the icon infiltrant, and we got a fantastic result. That's with the original protocol. It's nice when you see a very happy patient like that, because I had gotten a bunch of kits from the manufacturer to evaluate. So I just brought it in. So we did this at no charge for the patient. But we got something. I got a banana and a hug out of it, and that's more than. And look at that smile. That was fantastic. This is the three on the right are part of the kits. The left is the opalescent, not opalescent material. It's opalescent material from Ultraden for microabrasion that I'm going to describe. So as we've seen, case selection is critical to the success of caries infiltration. Icon offers new bridge between remineralization and restoration. So it ends the wait and see what happens with incipient lesion, and Icon offers the dental profession a method to treat upon discovery. This is great for white spots, but we're going to go into more detail. This is case we did recently. This is part from the article. When it's going to be reprinted in the journal, you see it in more detail. You can see the patient beforehand with the left, right, and anterior views with the white spots. Bleaching first with the Ultradent opalescent material. Isolate the tissue with their liquid rubber dam, and then bleaching 2 or 3 episodes of bleaching. And this is another case that was part of the article. We used the Ultradent opalescent, and that's 6.6% hydrochloric acid and silicon matrix particles for the brown spots. This patient had brown spots. This shows you the transillumination with the icon before applying the icon material. And these are the different components of the kit. And you can see over here, first you can apply icon etch while scrubbing. And it might be up a couple of minutes of scrubbing. You don't have to necessarily do the whole tooth. You could do the lesion. You apply the icon dry. You're going to transilluminate at that point and assess whether further etching is required with that. And then you're going to apply the icon infiltrate. Here we applied it for actually 9 minutes with continuous scrubbing. Want a maximum, but you don't want to use a curing light. So we used a transilluminator. We put a orange covering over that. A lot of companies make different shields. You apply that, so you're not going to cure the material, but you get some transillumination. And this is the result from the article with the combination here of microabrasion and some composite filling materials. Because patients having orthodontic treatments, that to do anything more invasive at this point is not necessary. She wanted to have her teeth look a little bit better prior to the orthodontic treatment. But again, you got to look at the sequence of treatment and what's best. So at the end of orthodontic treatment, other treatment might be more, probably more likely to need more further treatment, but we got to a pretty good result for the patient. Patient was very happy, as you can see, with a great smile. And I just saw this recently when I was on their site. If you're doing just a couple of teeth, DMG has a mini dam that you get stretch on the teeth and isolate the area. So that's another possibility. Otherwise, a full rubber dam would be fine. What are the indications for microabrasion? Hypermineralization, discoloration limited to the enamel surface, fluorosis, white spots, decalcification related to orthodontic bands. Contraindications, discoloration due to aging, tetracycline staining, amelogenesis imperfecta, dentinogenesis imperfecta, and decalcified lesions reaching the dentin and carious lesions. The simultaneous abrasion and acid erosion of the enamel prisms may compact the mineralized tissue within the organic area, and it'll place the outer layer of prism-rich enamel with a densely compacted prism-free region. And after the microabrasion, you get a lustrous, shiny, glass-like surface of enamel. Ted Crow, a pedodontist, came up with Prima many years ago with using this material, and you got a good aesthetic result. And you actually get enamel hardening with that, because you got chloride ions and silica incorporate into the enamel. This is a new material, not a new material, something I never heard of. Every time you think you know everything, it's never the case. Interesting material, and I'll show you my feeling when, where, why to use the different techniques, is basically for regenerating a carious lesion. It's a professional product, and it's clinically proven peptide technology, and basically induces enamel regeneration until the depth of the lesion and keeps natural tooth structure, and excellent clinical success, arrest caries, and it's great for initial lesion up to the dentin. Can be used with, compared to 34% with fluoride varnish, you get a much a better result with that. It's non-invasive also. So it's indicated for the treatment of active lesions, and it'll generate hydroxyapatite and heal the lesion from the inside out. It's not clinically indicated as a cosmetic treatment and may not change the deeply intrinsic stain and discoloration of the enamel surface. But again, when to use this and when to use the icon or microabrasion. Resin infiltration might be indicated when there's no internal discoloration of the enamel surface. So you can apply the Curodont to heal the active lesion. So again, that might cause remineralization, and then you still see the white, but it might not be as tense, and then you could go ahead and do the resin infiltration, but it does involve more than one procedure, and patients sometimes get very impatient. And here in the United States, I don't know how it is in Israel, we have to worry about insurance coverage. I don't know what the regimen in different countries, but here in the United States, a lot of people, if it's not covered by insurance, they don't want to do it. A resin infiltration does not generate hydroxyapatite. So if it's through the DEJ, you're going to want to use more non-invasive solution like silver diamine, but that stains the teeth black. Now, how is this done? Basically, the peptide diffuses into the depth of the carious lesion within 5 minutes. The peptides self-assemble within the carious lesion, and it'll form a biomatrix, and this attracts calcium and phosphate ions from the saliva. New hydroxyapatite crystals from the surrounding biomatrix end up regenerating the enamel. The progression of the caries is arrested, and the lesion basically disappears over time. So if you use it intraproximally, excuse me, we get some water. Use facially or intraproximally. This I would recommend rather than the icon for intraproximally, because once you treat it intraproximally, the lesion will gradually disappear on the X-ray. You won't see that radiolucency. While the icon is radiolucent, it'll still, even though it might be filled with the icon material, it'll still appear radiolucent. How do you apply it? First of all, you clean the tooth with a 2% sodium hypochlorite. You rinse, dry, you can etch with phosphoric acid, 37%, 35%. With that, rinse and dry, and then you're going to apply the material. You're going to slide it back and forth as indicated over here, and then apply it on the tooth. And in about 5 minutes, it's going to penetrate the tooth. So you hold the sponge firmly from its corners as you would a cotton pellet, and interproximally you use floss to apply the material. Unwaxed floor should be used to apply the etch for interproximal surfaces. And you don't need to use separators with the icon material. You have to separate the teeth. Like I said, it can be done, but I found it not that easy to use clinically interproximally, and the lesion would still show up. So personally, in my opinion, I would use this interproximally if you have incipient lesions around the icon material, or you could supplement it with the icon afterwards. But the liquid's quickly absorbed into the etched enamel. And when a lesion's visible on an X-ray, your prevention treatment didn't work out. So, fluoride varnish or other fluoride products should be used for prevention, but the cured-on repair material, or Fluoride Plus, is basically for night treatment afterwards. So when cured-on repair generates enamel with incipient lesions, the nucleoform hydroxyapatite crystals are deposited in a fan-shaped arrangement of the biomatrix, unlike the prismatic structure of natural tooth structure. This leads to slightly different optical properties as compared to natural enamel. Due to this, the wide appearance of the incipient carriers treated with cured-on repair may fade to a significant extent, but not completely disappear. As I mentioned before, I would use this possibly for incipient carriers lesion on the facial, and then if it's not satisfactory, use icon material to complete the better blending. So it has a low viscosity and high affinity to hydroxyapatite, and it'll bring about penetrate the depth of the carious lesion and bring remineralization. Other known remineralizations, such as fluoride, have been known to be more superficial remineralization and lead to the rest of the lesion. All right, but cured-on repair material, you get much higher, a better result, and restore the hardness of the enamel at a depth 8 times greater than possible with fluoride varnish. I used AI a limited extent. Mostly it's my brain that put everything together and researching it. But I wanted to get, I said, one of the questions I would ask is when to use one material, when to use another material. And basically this is the summary that AI came up with. Mechanism of action: cured-on used a bioactive material to remineralize enamel. Icon infiltrates and seals the dentin with a resin. So there's a difference. Curedent is ideal for early carious lesions, while Icon is suitable for non-cavitated white spots. Curedent required a simple application, while Icon, as I indicated, involves multiple steps for infiltration. Both aim to improve aesthetics, but Icon may provide a more seamless appearance. Durability: Icon tends to offer better long-term durability due to its resin composition. I haven't seen that much. Some people asked in a previous lecture I did about staining. There's been some change in color, but all the research seems to show it's minimal. Curedent would be less expensive. Sometimes the tooth is dark due to endodontic treatment, so you can do non-vital bleaching. The discoloration is due to pulp necrosis and bacterial byproducts. So you have the access to the root canal, but this is very critical, and I give you a whole bunch of articles on that. is barrier placement is very critical. Otherwise, you can have a problem. This is for internal bleaching. Saying apply the bleaching material or the whitening material inside the canal. Apply a temporary filling, they do a walking bleach. And if it's satisfactory, just apply a resin composite and you're done. And you can do inside-outside bleaching. You have a whitening tray and apply the bleaching internally in the tooth. Walking bleach, sodium perborate and water would be good. So it's H2O2, or that's hydrogen peroxide and sodium perborate. In school, you usually use the water and sodium perborate, less chance of problem that I'll allude to in a minute. And then you could use a carbonate peroxide material, or you can use the opalescent endo and apply it inside the canal. And I mentioned inside-outside bleaching. So it acts internally and externally, but once the optimal shade is achieved, you have to stop treatment. No need to use heat. Years ago, when I first started, we used to apply heat, but there's more chance of potential problem with that, and I haven't done that in many years. Side effects, possible cervical root desorption. That's why placement of a barrier in the correct manner is very critical. You want to protect the CEJ junction, so it's in a curve. It's not straight across that you have to apply the material. And it could be a glass ionomer material or a flowable material. I use glass ionomer most of the time, but you could get root fracture and possible color relapse. So you got to tell the patient that. And if you can do a veneer, whether bleach it first or not, prior to placing the veneer, sometimes you're better off just placing the veneer and allow for the darker tooth, because the color might relapse at a later change date, and it's going to show through the veneer. This is the walking bleach at 30%, 35 peroxide. This is a book I had a privilege of editing. It's published by Springer, and it's on porcelain veneers, but it goes over a lot of different clinical concepts, mostly materials, orthodontic treatment prior to that. I'm not going to go in detail. You could check the outcome, but a couple good articles in that I want to show you. This is one of the articles, and I just had this published in the International Journal of Aesthetic Dentistry in the February issue. There's a student in our adjacent program to the aesthetic program. Is a friend of the student that worked on, he worked on his friend, but he had severe fluorosis. He's from India with the high fluoride content in the water. That's a very common problem with the fluorosis. But you can see the degree of damage that was done to his teeth. So you want to improve his appearance. Whether the more minimal treatment that I mentioned before would have worked or not would be questionable. In the article we go into, he had some accelerated ortho done on number 11 with a corticotomy technique, and I can send you a reprint of the article if anybody's interested in more detail of the preparation and so forth. This is the veneer preparation, depth cuts on the labial and the incisal edge, and the final preps on the lower anteriors. The porcelain was done by Peter Pizzi Laboratory. Does a lot of lecturing for Vident. I don't know if his videos are accessible in Israel, but through Vident, he has some great videos. And you can see the final result that he was able to achieve. This is feldspathic porcelain, not lithium disilicate. And proper masking is critical, and knowing how to layer a porcelain is very critical. And the final aesthetic and happy patient. And this is from the chapter that I wrote in that book on discolored teeth, also with tetracycline staining. Again, by Peter Pizzi. It's the Willie Geller dye technique and the porcelain veneers and placement of the final veneers, and a happy patient. Thank you very much. That's okay. Let's see.
Thank you very much, Richard. We wait a little, we see if there have any question in Q&A and on the chat.
It was very interesting. Thank you. Thank you,
You can
Richard.
do stop
Thank you.
share.
I know I went through a lot very quickly, but again, if anybody has, any questions after, or they want more articles on that, they could email me. My email is rt587@nyu.edu. Okay, go ahead.
You can do stop share, Richard.
Okay.
No, it's okay because it is. If it's okay, we are recording it, and we have our
Website
on YouTube, the Israel Dental Association, and we have there about 150 to 100 webinars. All we do for our members. So they can enter, they can reuse and learn again and see again what we had about the webinars. So it will be published on our website. It's no money because it's for dentists in Israel, of course, as I told you, it's a part of continuing education that we do in association for our members. I think it's the first, the concept is, what about sandblasting? Oh, someone is writing here. Dr. Raphael Wax is writing, what is answering. What about sandblasting?
Well, I mentioned sandblasting. That's like your microabrasion with sandblasting. I mentioned aluminum oxide sandblasting. That would be a possibility. If you have a sandblaster, like I say, use a 50 micron, 25 micron aluminum oxide, and you could treat the lesion if you don't want to use the material from Ritchard with that, but you can use a finishing burr or diamond also. Any of those would be, like I said, unfortunately, it comes with use. You find which is most appropriate, most efficacious.
Two things. One is Professor Benny Peretz wrote that he thanks you very much for a most stimulative lecture. So Benny was a part of our audience, is the first of all. The second is another question. Do you have any articles about distinguishing the different color staining, white spot lesions, fluorosis?
Yeah, I have, like I said, when I wrote the article, before I write, I do a research, so I have a whole file on different articles. If they would send me email what they want, I'll forward the articles to them.
Thank you. Someone wrote it here.
Even recently, let's see, it keeps changing, like even with the using that Curadent, there's a whole bunch of recent material on that. So I have on the different lesions, and then there was one I could send with the article that was in QDT, because I could get that online. I could forward to them. They go over. That's where I learned a lot with updating the technique of that. That's why I asked the company about that. And any other questions? So again, they
Yes.
can email me and tell me exactly what they are looking for.
Thank you. One of the question is if the materials that you presented are available to buy in Israel, and you don't know, and really me neither. I don't know if some of them are commercials in Israel, and we can buy. But anyway, you people can check because they have already the names and the materials, and the active material is active substance in the
Which material?
materials.
The Curadent or the Icon? or both?
No idea. Maybe both of them.
Okay, because the DMG is a European, it's and I think the Curodont actually it's a Swiss product. But I could give them contact numbers and everything so they could follow up and get that. But I know it's available. I think both are available in Europe, so I don't know about Israel.
I think it is easier, much easier to buy them, and we are going to exhibitions, and we are medical tourists. We learn from others, so I
Exactly.
think another question. Let me check, please. Do you have? Thank you for your amazing lecture and wonderful cases. I used a palestra and it works well. Dr. Alessandro Satuchna.
Okay.
Something else more. Usually it's easy to get the materials from Germany, the DMG.
Okay.
Raphael, why do you protect the gingiva like in tooth whitening?
Well, some of the material could be very irritating to the tissue. Well, if using hydrogen chloride, it could, if it seeps under the gingiva, you can get damage to the bone. With the bleaching. If you irritate the patient with that, usually it's going to recover for that, but patient's not too happy. They can be sore for a couple of days after. But some of the other materials with the acid, you want to protect the soft tissue, and then you don't want it to get below the tissue. It could possibly affect the bone and cause problems. So you want proper isolation is critical with some of the techniques. With the icon material, if you're not going near the tissue, you could probably isolate it with a, like the Ivoclar has the, forgot the students use that all the time, just to isolate, retract the soft tissue. But if you're going anywhere near the gingiva or anything, you're better off being on the safe side and protecting with a rubber dam or with a liquid rubber dam, like with the bleaching. Rubber dam is more, and some people use a combination of rubber dam and Otradin has another material they could put under the rubber dam to really seal it with this like a caulking material, because you really want to protect those tissues. You could, besides being an unhappy patient, which you don't want, you could cause some major damage. I definitely would suggest proper precautions.
Someone, Dr. Stella Heisler, she wrote, Curodont is not available in Israel. So it's not available in Israel, but maybe people can find it abroad.
But again, I could give them the contact information, because I looked online. I got an 800 number. Somebody called me up as she was from Switzerland. So it might be possible if you call up, but they would ship it to Israel, even though it's not directly available for local dealer. They might ship it to Israel.
I think you can find a lot of materials through web, so it's not so complicated. It's much easier these days than in the past. Yes, definitely. Something else. Yes. I think that's all. Yes, I think that's all for today. Thank you very much, Dr. Ríčard Troskovsky. Hope to see you in Israel. Thank you. I hope.
Yeah.
I want to see you here again. I use the connections, and I hope to see you here with other subjects, because I know you have another good things to present to our members. So I will be glad if you agree to find another subject that you can give us more next month, next 2 months, doesn't matter. We are always be able to be here to listen to you, and thank you from the bottom of my heart for cooperation and contribution to Israel Dental Association.
It's my pleasure, and I could send you a list of a bunch of different topics. And
Okay.
you got to ask your participants what topics they would be interested in, because sometimes even if I don't have it, I have access to. I could develop different topics, which I learn a lot by doing that. And in clinic now, we got a lot of interesting situations, both aesthetically and restorative. So especially.
Yeah, we also be happy to publish more of your articles, of course, because we want to expose our members to more knowledge, and I think you are a great source of knowledge. And if we can learn something from you, it's our honor. It's our thank you.
Thank you. Like I said, we learn from each other. I thank you again.
Yeah, sure. Thank you very much. Thank you, מיכל. Thank you,
Thank
guys.
you.
תודה רבה.
Have a good night.
אני
Shalom
מקווה
to everybody.
שנהנתם. שלום, תודה רבה. Thank you very much, Richard.
Thank you, Richard.
Thank you. Good night.
Thank you. And thank you, Michelle. How do you pronounce your name and the first name?
Michal.
Michal.
מיכל.
I got it. Yeah.
You know, in Hebrew, we have a lot. So it's
Yeah.
מיכל.
That's a beautiful
Yes.
name.
Of course, beautiful woman, beautiful name.
Thank you.
Why not? All right.
Good
Very
night,
good.
everybody.
Thank you very much.
Thank you very much. Good
My
night, good
pleasure.
night, guys.
All the best.
Thank you.
Bye.
Bye-bye.
Bye.
Bye.
Bye.